transitioning to that 20% of patients where they don't present with systemic disease. And we know that surgical is the only way to cure these patients who oftentimes have micrometastatic disease that we can't detect. So there's been a lot of discussion lately, and Tony and I were just at a fascinating meeting where we listened to some surgeons talk, and now I'm completely taken with some of your Mayo Clinic surgeons. And I still will say I was his RA in college. So the multidisciplinary approach to these patients, and how do you now define, because it's changing and evolving, the resectable patient versus the borderline resectable patient?
So really at this point, the way you want to think about it before you think about a discussion, because the surgeon ultimately will help you and the radiologist will help you decide. But clearly there's the clear resectable, the borderline, and the unresectable. And the clearly resectable are those that are free of any involvement, abutment of any blood vessels or major vessels or celiac plexus. And then the borderline resectable are those that, somewhat in the gray zone. You're not sure that you're going to get a clear R0 resection, and so, but you think there's a 50% she may, and so you clump them in that borderline. And the clearly unresectable are those that involve, say, the superior mesenteric artery and celiac plexus, just wrap around it, completely. And that takes us essentially to the importance, because there's, even in that white, black, and gray, there's still a lot of grayness. And this is why it's incredibly important for those patients to be assessed, every single one of them to be assessed in a multidisciplinary setting with a surgeon, radiologist, and the medical oncologist involved.
Yeah, and I think, and I want to get into this discussion in a minute, there's this whole concept of, even in the resectable patient, going with a neoadjuvant approach rather than straight to surgery. But before we go there, I want to talk a little bit more about the data that we've seen for adjuvant therapy for pancreas cancer. Manuel, what have we used? What are you using now? There's a little controversy going on, and then there's a randomized phase 3 study that we're waiting for the readout, hopefully relatively soon.
Yeah, there are a couple of them. There is the FOLFIRINOX study as well, is completely enrolled. So we have the APAC and the FOLFIRINOX will be released soon. And SPAC4, which is published a few months ago, actually. So in the adjuvant setting, we have moved away from radiation. We're not using radiation in any form, neither external beam nor SBRT or CyberKnife. And most patients are getting gemcitabine and capecitabine these days. Though, SPAC4 is a study that is complicated to understand. To me, it's very clear that the R0 resection, the benefit appears to be quite substantial. There is a small group in that study, only about 30% of the patients. In the R1 resection, which is 70%, the benefit of adding capecitabine is not that impressive. That's number one. Number two is that really, I don't know in how much detail we need to get into, but it's very interesting that the study was powered to detect a hazard ratio of 0.74, right?
Yeah.
And the hazard ratio is 0.82.
Yeah.
The p-value is still significant. and I think how the statistics work, it's still a little bit of on an enigma. There are no differences that in the 2-year survival, which is what, with the follow-up that the paper was published, 30 months or 30 few months, it's probably what you want to look at. The projected 5-year survival is better, but that's projected. We need to wait for the follow-up. So I think that GenCap is a good rate. It's more toxic, of course.
Yes.
So I think it's a good regimen, but there's still some patients that could be managed with with gemcitabine alone. And of course, if we were in Japan, we would be using S1, but we're not, right?
Yeah.
Well, I think the important thing is that patients get adjuvant treatment. That's, I think, what we can clearly say from all the trials. I mean, an aspect for what I take is that it's the right way, that combination may confer additional benefit, but we don't know whether this is the optimal combination. We will see the data, and maybe we'll have to identify the subgroup of patients that really benefits from this treatment. And the problem with adjuvant is we only treat those who can get it. And this is down to 50% of patients post-op because of perioperative morbidity. This is one of the problems, we selecting already the good ones in this case.
So I mean, there are a lot of issues because, of course, these studies have been conducted over the last 15 years, and things have fortunately changed. Something that changed is the management of metastatic disease. So how much of the survival differences that we see now is not because we're having better regimens when the patient relapse, and perhaps the relapse are being detected even earlier as we monitor them more aggressively, and we're treating oligometastatic disease in a much more aggressive manner than we did before. So it's all a complicated
Yeah, I still have a lot of people that send folks to me for second opinions where they're using GemNab early as adjuvant therapy.
Okay.
And so we're waiting for APAC. Winson, tell us a little bit about APAC.
Yeah, so we're all kind of waiting anxiously for the results. I think we're optimistic that it might show some improvement. I mean, for the time being, we haven't, jump on board yet and adopt that therapy. I mean, I agree with Manuel. Right now, GemCap is a standard in Canada for adjuvant setting. There's really very little role for radiation in Canada as well. It's not used very heavily at all. So until we see, phase 3 evidence, we haven't really, extrapolated and done that.